I think early pregnancy loss is one of those topics students find surprisingly difficult.
Absolutely. Mostly because they try to memorize classifications without understanding how a patient actually presents.
Exactly. So in this discussion, we're going to build the topic from the clinical presentation upward.
And before we start, a quick disclaimer. This discussion is intended for examination preparation and educational purposes only. It is not a clinical guide for hospital treatment or patient management.
Always follow your local protocols and specialist guidance when caring for actual patients. Let's start with a question. A woman comes to the emergency department at 8 weeks of pregnancy with vaginal bleeding. What's the first thing that comes to your mind?
Most students immediately think of miscarriage.
Which is understandable.
But interestingly, around half of the women who experience first trimester bleeding may still have a viable pregnancy.
That's an important number.
It is, because bleeding alone doesn't tell us the outcome.
And age plays a huge role here, doesn't it?
Yes, as maternal age increases, miscarriage rates rise substantially. Chromosomal abnormalities become increasingly common.
So already we're seeing that pregnancy loss is often a biological event, rather than something the mother caused. When such a patient arrives, do you start thinking about the diagnosis immediately?
Not quite. The first thing I think about is stability. How much bleeding is occurring? What are the vital signs? Is there dizziness, syncope, or evidence of shock? Because before we diagnose anything, we need to know whether this is an emergency.
Right. Mild spotting is one thing. Heavy bleeding with hypotension is an entirely different situation. Now, once the patient is stable, what are the major first trimester pregnancy complications that we can think of?
Keep these 3 complications in mind. Anembryonic gestation, where the gestational sac develops and grows, but embryonic tissues never form. The second is a subchorionic hemorrhage, in which blood collects between the chorion and the decidua. It is often incidental, but it increases the risk of miscarriage if it is large. The third one is embryonic demise. The embryo forms and attains an identifiable size, but cardiac activity ceases. And the diagnosis everyone fears missing. Ectopic pregnancy should always be on top of your mind.
Exactly.
Because among first trimester complications, ectopic pregnancy has the greatest potential for maternal harm.
Why do we often struggle with beta-HCG?
Mostly because we try to memorize numbers rather than understand the concept.
So, what's the key idea?
The discriminatory zone.
Meaning?
Above a certain beta-HCG level, we would generally expect to see an intrauterine pregnancy on transvaginal ultrasound.
And if we don't?
Then, concern for ectopic pregnancy increases significantly.
So ultrasound and beta-HCG are really partners rather than separate tests.
Exactly.
One thing that's changed over the years is how conservative the diagnostic criteria have become.
And for a very good reason.
We don't want to diagnose pregnancy failure in a pregnancy that might still be viable.
Correct. Modern criteria are intentionally designed to maximize specificity.
Which means we're willing to wait and repeat imaging if uncertainty remains. If you had to teach miscarriage classifications in 1 minute, how would you do it?
I would focus on 2 questions. Is the cervix open or closed? And are the products of conception still present?
That's actually much easier than memorizing 5 separate definitions.
Exactly. Once you answer those 2 questions, threatened, inevitable, incomplete, complete, and missed miscarriage become much easier to distinguish.
Let's return to the diagnosis we never want to miss.
Ectopic pregnancy.
What makes it so dangerous?
The potential for rupture and internal hemorrhage.
And sometimes the presentation can be deceptively subtle.
Exactly. Mild bleeding, mild pain, yet a potentially life-threatening condition.
Which is why every first trimester bleeding case requires a systematic approach. Once a diagnosis is established, management usually falls into 3 broad categories.
Expectant management, medical management, and surgical management.
And it is not the best treatment that we chose, but the safest, given the patient's condition, right?
Exactly.
Let's talk about what examiners love asking. What are the complications that we should keep in mind?
Massive hemorrhage, septic abortion, neurogenic cervical shock.
If we remember those three, we are already covering the most important acute emergencies, right?
Exactly.
So if we step back and look at the entire topic, what's the framework? We have a positive pregnancy test, and the patient is in the first trimester and is bleeding.
Resuscitate if unstable and go for a transvaginal ultrasound and beta HCG. The first question is whether the sac is empty. An empty sac indicates an ectopic pregnancy.
The discriminatory zone is used for decision-making here, I believe.
Exactly. Presume ectopic if beta HCG is greater than the discriminatory zone. If smaller, we follow serial 48-hour tracking. Apply strict criteria and diagnose viability versus miscarriage for all intrauterine pregnancies.
And never forget the potentially life-threatening complications.
Exactly. And if you can follow that sequence, you'll not only perform well in examinations, you'll also understand the clinical reasoning behind early pregnancy loss.
Is there an aftercare and recovery plan?
There should be a physical protocol and a psychological protocol. RH immune globulin administration, confirmation of complete passage and discontinuation of historical myths. Acknowledge and legitimize grief, address guilt, and talk about future conception. Lack of psychological support is an incomplete treatment.
Exactly. With this, we come to the end of the discussion. Thanks for your participation. We shall see you next time.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.